So the hardest thing to say is that there isn't any one thing. You guys know that, right? This is a multifactorial disorder. It's one in which it's not just the biological predisposition, it's the genetic predisposition, it's a psychological aspect. How does the child cope? What kind of incidents and experiences, positive or negative, have they experienced? But in addition, what kind of social factors? And I raised that 1684 just to point out that everybody keeps on saying that this is a new disorder. This is a new, society created this, the media created this. I don't think there was very much media in the 1600s, I have to say. So I think that this goes back further and deeper than we have really previously been thinking, and I think it's important to acknowledge that. In terms of saying, guilt, and where does this come from, one of the things that we do know is that there is a genetic predisposition to eating disorders. We do know that if you have a child with anorexia, the probability of someone else having it in the family is about 5 times higher than in the general population. With a first-degree relative with bulimia nervosa, we're talking about almost a double-fold. And in twin concordance studies, it's there. In anorexia nervosa, 30 to 50% concordance rates for anorexia. For bulimia, 60 to 83% concordance rates. And I mention that because I think that it's clear it's not 100% genetic, and it's not 100% psychological and coping. It is some very complex combination of them both. But when thinking about from a biological perspective or from a medical perspective, the interventions that we have, again, it's kind of like taking a sledgehammer and trying to chase my children. It doesn't work very well. And it's very complex. And so I think it's important to also note that the comorbidities are actually where I focus my treatment. The reason why is because depression, anxiety, and OCD are in higher rates. That's a no-brainer, right? The overlap rates of OCD in the adult population, 30%, sometimes rated as high as 50% in eating disorders. When you think about comorbidities in anorexia, patients with anorexia, 55% of them or approximately have comorbid psychiatric disorders. That's important. We don't have a single treatment for anorexia, but I do have treatments for depression and anxiety and OCD. In addition, for bulimia nervosa, it's more important because 88% of patients with bulimia nervosa have comorbid psychiatric diagnoses. In addition, they have an increased rate of suicidal ideation, 53%, plan for self-injury, 26%, and 35% of them have attempted suicide. That's incredibly hard. These are things that I think sometimes get underplayed. And so when I think of treatment, I think of where I started, which is back in Children's Hospital, and the first point of interaction for most patients with eating disorders is actually in the medical field, whether or not they show up in the pediatrician's office, the urgent care, the emergency room, the school nurse calls them in. Often their first interaction is with a medical doctor. And the reason why is because of the medical severity. Patients with eating disorders have not just the highest rate of mortality for all psychiatric disorders, but are at an increased rate of 12 times more, increased rate of mortality than the general population at large. I won't go through all of the organ systems, but I do want people to be aware of the fact that in addition, so in Children's Hospital, it was very much about stabilizing the bradycardia, nutritional rehabilitation, electrolyte balances, and prevention of the refeeding syndrome. But as I've moved into the residential program, I've noticed I'm still managing dysmotility problems, chronic constipation. I am dealing with the fact that there is a 30 to 40% overlap of abdominal pain and discomfort in patients with eating disorders. I'm battling that every day, so I'm still practicing in some realm of medicine. In fact, it's so important and it crosses so many realms that it was actually the American Academy of Pediatrics, as well as the Society of Adolescent Health and Medicine, that had to define the parameters for medical admissions for patients with eating disorders, because it was all over the place. The bradycardia, the heart rate, the orthostasis, how abnormal does your EKG have to be? People are still sort of debating and trying to come up to terms with, well, when do we say that this is really dangerous so that we can avoid other medical mishaps? In terms of medications, the way that I like to think of it is I focus first on the the psychiatric comorbidities. The reason being is that there is more evidence. To date, there's no FDA medication for the treatment of anorexia. There is one FDA medication, fluoxetine, which is Prozac, which is FDA approved for the treatment of bulimia nervosa. It reduces the urges for binging and purging, but it's important to note that even though it's FDA approved, the robustness of the studies is still very limited. There is a lack of head-to-head trials, and multiple medications have tried. In addition, antipsychotics, which were first tried in the 1960s for the treatment of eating disorders, the first generations were not as effective. The third generation, they've done several placebo-controlled trials. Of the 3 antipsychotics that they've tried, olanzapine comes ahead slightly. It helps reduce rigidity, anxiety, sometimes even agitation, perseverative thoughts, and then capitalizing on the side effect of its effect on the histamine receptor, which, if anyone's taken Benadryl, sleepiness, tiredness, increased appetite, weight restoration. For binge eating disorder, there are some new novel techniques, ondansetron, Topamax, lisdexamfetamine. There's some other medications that have been tried, but so much less is known about binge eating disorder that I couldn't even give you controlled trials, studies. They don't even have really good epidemiology for binge eating disorder in this country. So that's all I've got. In conclusion, I think this is sad that, it's wonderful to get together. It's sad that there's such a limited amount of information that I can present to you in terms of the data, in terms of where we've come. But I think that it does point out the fact that we're all here is a wonderful example of how we can bring awareness as well as educate each other about other resources and hopefully move forward with the treatment of eating disorders.